Access is the key of success because most of the complication, at least 50% of all the complication in laparoscopic surgery happens during the time of access. If your access is not good, then always you will have apprehension and your complication rate will be high. So it is very important that we should learn the access technique. In access technique are different type, and today I am going to discuss some of the important access technique. Access technique has two parts. One part is entry of the optical instrument and another part is entry of the secondary port. So the primary instrument is very important for the safety point of view. And secondary instrument is important for ergonomics point of view. Because most of the complication happens at the time of putting your primary port. And secondary port is always under vision, so you will not do much complication in secondary port. But secondary port is important for ergonomic point of view. If our secondary port is at wrong place, throughout the surgery we will struggle. And if the primary port is wrongly introduced, then we might have a lot of complications. So this has two parts of this lecture. Right now I am taking first part, that is access technique, and the baseball diamond concept of the port position I will take in the second part. So let me start. So this is the access technique, and we will see how to do the initial access, that is the first part of the technique. Where should I put my port? This is a very common question asked. Whenever you will start any new surgery, this comes in your mind that where to put the port. And statistical data has shown that most common cause of stressful surgery is wrong port position. If your port is wrong, you will struggle. You need a correct planning, you to develop a skill. You should have idea about the target and a strategy, then only we can have the goal. If your port is at wrong place, you will have a lot of time in the surgery. And surgery will be expensive as well. Because if you have a wrong port, you will struggle and your time of the surgery will be more. And it will be more expensive also because anesthesia time is more. You have to use the advanced instrument like a stapler, different type of auto suturing devices. So it is very important that we should have correct port. Now, once you have decided, then optical port is also called primary port. That is also called optical port. And there are 6 sites for optical port. First is supraumbilical, that is above the umbilicus. Second is infraumbilical, that is below the umbilicus. Third is superior crease of umbilicus. This is also called crying incision. Fourth is inferior crease of umbilicus. That is called a smiling incision. Fifth is transumbilical. That is on the base of the umbilicus. And sixth is Palmer's point. These are the 6 sites of the primary port. Most of the cases, these are the only 6 sites which we use to enter into the abdomen in laparoscopy. In retroperitoneoscopy, we have the different site. In extraperitoneal surgery, like totally extraperitoneal hernia, we have different site. In axilloscopy, we have a different site. But as far as laparoscopy is concerned, these are the only 6 sites which you can use to access. Whenever you have to do any upper abdominal surgery, then you will use supraumbilical port for any upper abdominal surgery. Supraumbilical means above the umbilicus. Now question is, how much above the umbilicus? Normally, In the normal patient, it should be 18 centimeter below the umbilicus. That should be 18 centimeter. Why 18 centimeter? Because adult instrument length is 36 centimeter. So if you will use 18 centimeter, then half of the length of the instrument will be inside the abdomen and half of the length of the instrument will be outside abdomen. So that's why it should be 18. Like if you will see most of the instrument, this length is 36 centimeters. So 18 is the half. So that's why we should have half instrument inside the abdomen and half instrument outside the abdomen. And if it is a bariatric patient, your instrument length is 45 centimeter. Like you can see here, this is a 45 centimeter instrument. So half of the 45 is 22.5. So suppose you are doing bariatric surgery or any surgery where the bariatric patient is there, like even if you are doing the fundoplication, but if it is a bariatric patient, it should be 22.5 centimeter below the umbilicus. So that is called supraumbilical port. After that, in gynae, approximately 80% of all the operative gynecological procedure, we use supraumbilical port. Like hysterectomy, myomectomy, sacrocolpopexy, in all those cases, supraumbilical port is required. Why it is essential? Because with the uterine manipulator, you can give cranial traction. If you will go through the umbilicus and then with the uterine manipulator, you will give cranial traction, fundus will touch the telescope and you cannot perform the surgery. So that's why 80% of all the gynae procedure, supraumbilical is used. Now coming to the infraumbilical. Infraumbilical port is used for deep pelvic surgery. Like it is performed sometime for pre-sacral neurectomy or for Luna, or sometimes some of the spaces where you have to enter into the space of Regius, you are using infraumbilical port. Although it is less popular, it is not very popular, but tubal ligation, when they do single puncture tubal ligation, then infraumbilical is used. Infraumbilical is also used by the general surgeon when they have adult instrument and they have to perform pediatric surgery. At that time, they use infraumbilical because suppose you have a very small child, like that much a small child, and here is the gallbladder, and this is the cystic pedicle, and this is the umbilicus, and your instruments are long, but you are doing pediatric. At that time, they use infraumbilical so that they can perform the pediatric surgery also with the adult instrument. Now, over the umbilicus, there are three sites. One is called superior crease of umbilicus. This is also called crying incision because it's like a crying face. This is like a crying face. Second is transumbilical. That is on the base of the umbilicus. That is on the deep pit of the umbilicus. That is called transumbilical. And third is a smiling incision. That is over the inferior crease of umbilicus. So these all three are umbilical incision. Remember, supraumbilical and superior crease of umbilicus is different. Infraumbilical and inferior crease is different. We should not consider inferior crease as infraumbilical. These all three are umbilical. And in umbilicus itself, we have three sites. One is superior crease, second is transumbilical, and third is inferior crease. And the last is Palmer's point. Palmer's point is the most attractive site of the primary port position whenever umbilicus is diseased. This is called Palmer's point. Here we can see this is the mid-clavicular line and this is the costal margin. Here we have the costal margin. This is costal margin and this is Palmer's point. Palmer's point is the most attractive site of the primary port position wherever you have umbilicus is diseased. Like suppose patient has umbilical hernia or umbilical sinuses or infection of the umbilicus or any other midline incision which is reaching up to the umbilicus. In those situations, you should always prefer Palmer's point. Palmer's point has many advantages. One of the biggest advantage that this is only part of the hollow viscous in the GID which can be deflated. So you can deflate it. How you can deflate it? By NG tube. You can put one nasogastric tube and you can deflate. Second is that it is a sterile organ. It is sterile, means below is the stomach. Here will be esophagus and here will be a stomach. So due to a stomach, even if it is suppose punctured by the varus needle, there is no much concern because it doesn't have bacteria, it has only acid and enzyme, and that doesn't allow any bacterial peritonitis. It can only do chemical peritonitis, bacterial peritonitis not happen. Third advantage is that this costal margin keep it completely away from the underlying viscera. So this costal margin, the rib is keeping it lifted up. This is one of the biggest advantage. And fourth advantage of this is that it is a good organ to perforate. This is a good organ to perforate. What does it mean? Why should I perforate? Do you know when they do transgastric surgery? Like in the female, when the natural orifices transluminal endoscopic surgery is performed, then they do transvaginal. But in the male, it is transgastric. You can put an endoscope in the mouth and you can perforate the stomach and you can take the gallbladder out through the mouth. So if you will give a high dose of proton pump inhibitor, even it perforate, then later you can suture it. That's how they do natural orifices transluminal endoscopic surgery. So that's why Palmer's point is the most attractive site of the primary port position whenever umbilicus is not possible. Whenever umbilicus is not possible, then you should use Palmer's point. So these are the 6 sites for the primary port position. Now, among the umbilicus, you have 3 sites over the umbilicus. One is superior crease, another is transumbilical, and third is inferior crease. Among this, inferior crease is considered as better compared to the superior crease and transumbilical. This idea was given by the Scandinavian surgeons. That's why it's a part of a Scandinavian technique. This is also called a Scandinavian technique. Why inferior crease is better? Because central location, less swording and easy access. It has less chances of hernia as well because center of gravity, umbilical tube, valve action and confluence skin. And it has a less chances of infection as well because no bacterial flora and dry surface. So that's why if you have suppose umbilicus and you need superior crease or transumbilical or inferior crease, you should prefer inferior crease. Many surgeons, they say that inferior crease has a smiling, so if you give a smiling incision, you keep on smiling. Because over the inferior crease, you have the obliterated vitreointestinal duct, which can be dilated and it has a valve action. So once you take your port out, spontaneously it closes. And chances of hernia, chances of infection, chances of the swording will be minimum if you use inferior crease of umbilicus. So let us start now how to enter. First, you should check the varus needle and you should check for a spring action of the varus needle as well as it should be patent. So how to check a spring action? Already Dr. Valla has demonstrated you that this is the spring and you can see it is giving you the sound. This is called a spring action. So a spring action should be checked and after that you take a syringe and you check for the patency test. So you will do like that and we can see it is going. This is patency test. So once the spring action and patency test is checked, and it is okay. After that, you will take 2 Allis forceps and apply these Allis forceps either side of the umbilicus. You will apply these Allis forceps, and then with the 11 number, of the knife, you will stab the inferior crease of umbilicus. Remember, don't use 15 number. 15 number is round like that. It has a round surface. 11 number has a pointed. So we should use 11 number of the knife and stab the inferior crease of umbilicus. Only 2 millimeter stab wound should be given. It should not be cut complete 11 mm. After that, you should take the varus needle and you should hold the varus needle in such a way that it should be protected according to the thickness of abdominal wall, and it should be held like a dart. This is the way to hold the varus needle, like a dart. And this naked part should be 4 plus thickness of abdominal wall. Like suppose this is the abdominal wall, and if it is 2 centimeter, then 2 plus 4, that means 6 centimeter of this varus needle should be naked, and rest of the part should be guarded. And this is how we should hold the varus needle. And we can see in this video that this is the varus needle which is tenting the peritoneum 4 centimeter extra and then puncturing it. And this blunt tip comes out. And advantage of this blunt tip is that even it will touch the bowel, it will not perforate the bowel. And that's why we should use the varus needle, and it should be held like a dart. And we should point it towards the anus. So we should hold it in such a way that it should be perpendicular to the abdominal wall but oblique to the body. It should be perpendicular. So we should lift the abdominal wall in such a way that it should be perpendicular to abdominal wall but oblique to the body. And lifting of the abdominal wall should be done with the thenar eminence and all the 4 fingers. And after that, you will enter. So how to do in this video, we will see that just you will give one small stab wound over the inferior crease of umbilicus, then hold the varus needle like a dart, put it over the inferior crease, lift the abdominal wall, and then you have 1 click and then 2 click. After that, you will take a syringe, and then you do irrigation test first. This is irrigation test. And then you should do suction test. And after that, we should do hanging drop test. Lift the abdomen, hanging drop is sucked in. And that way we can make it out, and this will be the best method of entering the. And once it is introduced, after that you have to look at the insufflator and you have to look at the quadromanometric indicator. This is called quadromanometric indicator. What is this quadromanometric indicator? Over the insufflator, there are 4 indicators. One is preset pressure, another is actual pressure, third is flow rate, and fourth is total amount of gas used. This is called quadromanometric indicator. This quadromanometric indicator we will discuss in detail at the time of demonstration of insufflator. But you should remember that within first 5 seconds, your actual pressure should be single digit. It should not become double digit. Preset pressure is the command which you give to the insufflator. When you are doing thoracoscopy, preset pressure should be 6 millimeter of mercury. If you are doing laparoscopy under local anesthesia, preset pressure should be 8 millimeter of mercury. Normal surgeries, intermediate level of the surgeries, preset pressure should be 12. And in advanced surgery, it can go maximum to 15 millimeter of mercury. So this is called preset pressure. Actual pressure will give you real pressure. Once the actual pressure will reach to the preset pressure, flow will automatically stop. Flow rate for the varus needle should be 1 liter per minute. And for the cannula, it can be 6 to 10 liter per minute only. It should not be more than that. More than that only in emergency, if the vessels are ruptured or something, then only. And total amount of gas used. Minimum amount of gas required to reach to the pneumoperitoneum desired actual pressure is 1.5 liter. and maximum amount required is 6 liters. So this is called total amount of gas used. This is I am talking about before putting a trocar. Before putting a trocar, minimum amount of gas which is required with the varus needle to distend the abdomen is minimum 1.5 liter and maximum 6 liter. What are the criteria? First is depending upon the size of the patient. If patient is very tall, he can take more gas. Second is your laxity of the abdomen. Like under local anesthesia, we can put less gas. If patient is under general anesthesia, fully muscle relaxant is given, then we can put more gas. Third criteria is bowel preparation. If the bowel is nicely prepared, we can put more gas. If bowel is not nicely prepared, we can put less gas. And fourth is your any space occupying lesion. Because if the patient has only a large ovarian cyst or large fibroid or large tumor or any other pathology or hemoperitoneum or ascites, we can put less gas. So this is called quadromanometric indicator. Once the quadromanometric indicator is satisfied, after that we will put our port, that is trocar. That is the first trocar. So first trocar should be introduced once quadromanometric indicator is satisfied. After that, we should extend the incision to 11 mm and we should aspirate the fatty tissue by the Kelly clamp or mosquito forceps. You should aspirate it. And once it is aspirated, after that, this aspirating will also dilate the obliterated vitreointestinal tract. So you should take a mosquito or Kelly clamp and you should go inside, open the jaw, come out, open the jaw, come out, open the jaw, come out. And then you should hold the trocar in your hand like a pistol. This is the way to hold the trocar. Already Dr. Bhalla has demonstrated you that this is the trocar and this is the cannula. So head of the trocar should rest over the thenar eminence. So we should hold it in such a way that this is the way to hold. Head of the trocar should rest over thenar eminence. Middle finger should wrap around the air inlet and index finger should be pointed toward a sharp end. And this is the way to introduce the trocar by a screwing movement. A screwing movement is only not allowed in cases of this disposable trocar, because in disposable one there is a blade. So bladed trocar you should not screw, you should go in one go. But non-bladed trocar, always we should go by a screwing movement. So how to go, we will see in this is the how you should screw it. In the bladed one, like this is disposable, in this there is a blade here. You have to charge it first. This is how you have to charge it first. This is a disposable. Disposable should must be taken carefully. And here we will see how you will charge. This is the disposable trocar and here you will charge it like this. This is charge. And once it is charged, you can see there is a very sharp blade. This is very sharp blade. This is the blade. Very sharp blade here. It can cut your finger. It is very sharp. And in this one, you should hold like that. But this one, we should never try to screw, because it will get discharged in the halfway. So we should hold it and we should introduce by direct one go. And as soon as you go, now second time it will not come, because it can fire only one time and then get discharged. And again, if I want, I have to charge it. So how to do? You have to, this is charging. This is charging knob. And when I will press it, it is charged. And after that, in one go, I should enter like that. And in this one, we should not screw. So this is bladed trocar, although it is less used because it is little risky. It can, cut the inferior epigastric vessel. So even in disposable nowadays, bladeless trocar is preferred. Like you have the bladeless trocar. These are bladeless. And these are optical. Optical is also, VG port is also there, which you will see in our lab. We have, these are optical ports. And this is bladeless. So in this one, you should hold like that. And we should enter by a screwing movement. Here we go by a screwing movement and we should enter with the screwing movement like that. This is a screwing movement. So here also we should hold it like this. and you can attach the camera here, and then by a screwing movement, you can enter inside. This bladelet trocar is available in 10 mm as well as 5 mm. In this 5 mm, you can introduce the 5 mm telescope. There is a lock here, and once I will introduce it inside, after that, this lock I can lock it, and then this telescope will not come out. It's not dropping. It is stable, and this is also bladeless. And we will hold it, and by a screwing movement, you will enter inside, and telescope can be attached here. So these are called optical port. We have one VG port also. So we will see VG port. Dr. Valla will demonstrate you VG port, which has a pistol grip. And I will also show you here how to do that. So this is very important, that how you are holding the trocar is very important, because if trocar is not held properly, there may be some problem. So this is important to hold it in a correct way. So this is how we have to hold it, and once it is held, after that you can start entering. So this is how, with the screwing movement, you will enter inside. So we'll see in this video how to do that. That this is the extension of the incision. After that, dilating the vitelo-intestinal tract, then holding the trocar like a pistol, and by a screwing movement, perpendicular to the abdominal wall, you will enter inside the abdomen. After that, white balancing and focusing will be done by your assistant. You will attach the telescope into the cannula. This is white balancing and focusing is already done. And how to do that, we will learn it. We will demonstrate you the camera, and then we will learn it. And then you will enter inside. So this is the technique of introducing the primary port. The primary port means optical port. And after that, you will start the procedure. There are many, if the patient is, suppose the pediatric patient, then in pediatric patient, it should be little different way. Because in pediatric patient, you should try little bit careful. So this is a pediatric patient. We can see 2 Ellis forceps will be applied either side. After that, with the 11 number of knife, you will stab the inferior crease of umbilicus. Here it is stabbing the inferior crease of umbilicus. This is stabbing. Then hold the varus needle 4 plus thickness of abdominal wall. So here abdominal wall is only 1 or 2 centimeter. So there should be 6 centimeter. You will hold it with the thickness of abdominal wall. And rest of the varus needle should be guarded. So this is, that much is only naked, and rest entire part is guarded. And you should hold it like a dart. After that, we should lift the abdominal wall by your thenar eminence and all the 4 fingers. Remember, some people, they use towel clip. Towel clip should not be used to lift the abdominal wall. Do you know why? It stretches the skin alone. We need to lift the entire thickness of abdominal wall. So with the thenar eminence and all these 4 fingers, we should try to lift the abdominal wall. And after that, it should be pointed towards the anus. So the angle between the varus needle and abdominal wall is 90 degrees. An angle between the body of the patient and varus needle is 45 degrees. So do you know what is the difference? It is perpendicular also and oblique also. It is perpendicular to abdominal wall but oblique to the body. So what is the advantage? Because if it is perpendicular to abdominal wall, so it will not go to the periperitoneal space. And because it is oblique to the body, so it will never go to aorta or vena cava. Because aorta is 5 centimeters above the sacral promontory. So it will not go. So it should be perpendicular also and oblique also. Perpendicular to abdominal wall, this is abdominal wall, and it is perpendicular 90 degrees from the abdominal wall. But in relation to the body of the patient, it is 45 degrees. And it is pointing towards the anus. So this is how you should lift the abdominal wall, and then you will get 2 click. And this is first click. And first click is due to rectus. And then you will go second click. And second click is due to the peritoneum. So we can see here, this is the, again I will show you. So lifting the abdominal wall with the thenar eminence and all the 4 fingers, and this is, you will lift it, and this is your first click, this is first click, and then second click. After that, you will take a syringe and you will do irrigation. This is irrigation, and then this is suction, and this is suction, and then we have hanging drop. This is called hanging drop. Here we can see this is a hanging drop. Hanging drop. And once you will lift the abdominal wall, this hanging drop will be sucked in. Why? Because by lifting the abdominal wall, it will create negative pressure. This will create negative pressure. And due to that negative pressure, it will be sucked in. So we can see here you will lift the abdominal wall and see it is sucked in. That is called hanging drop test. And after that, you will attach the tubing of insufflator. And here is the tubing of insufflator. And then you will start the flow. Flow should be 1 liter per minute. 1 liter per minute for adult. And for pediatric, 0.1 liter per minute per year of the age. Per year of age. Like if it is a 1-year-old child, it should be 100 ml per minute. 2-year-old, 200 ml per minute. 3-year-old, 300 ml per minute. And after 10 years, it should be same like adult. So as soon as you start the flow, and as soon as 200 ml gas has gone, then you should palpate the abdomen, and you will get a liver dullness will get obliterated. And it will get a homogeneous distension, and you will get a tympanic sound. Here you will get a tympanic sound. After that, your eye should be over the insufflator. Your eye should be over the insufflator. And you can see here, this is a pediatric mode. Preset pressure is 8. Actual pressure is slowly increasing. And flow rate is here 0.7 liter. 0.7 liter. Why? This is a 7-year-old child. So it is 0.7 liter per minute. And this way you will start the flow. And once the flow will reach, after that, it will stop. So this is very important, that your flow rate should be adjusted in such a way that it should be 100 ml per minute per year of the age in pediatric patient. In adult, it should be 1 liter. Why? Because even if it is going in any vessel, patient will not get air embolism. So that's why it is important. And after that, once it is satisfied, then you will remove the varus needle and then enlarge the incision either side. We can see here, now 8 is reached. And once 8 is reached, the pneumoperitoneum is created. Now take the varus needle out, and then we have to extend the same incision to 11 mm. Not 10 mm, 11 mm. Because outer diameter of the cannula is 11 mm. And this is called a smiling incision. This is a smiling incision. Then we should take a mosquito and dilate the obliterated vitreointestinal tract like that. After that, we should hold the abdominal wall completely with our thenar eminence and all the 4 fingers and lift it, and by a screwing movement, you should enter inside. And then you will get a hissing sound. A sound will come, shh, sound will come, because tip of the trocar has one eye, and that eye is communicated with the back. If you will see very carefully, then this tip of the trocar has one eye here. This is one eye. And this eye is communicated with the back. So this type of sound you will hear. And after that, you remove the trocar, then push the cannula further in. And then you will attach the tubing of insufflator and then increase the flow rate to 10 liter per minute. Remember, 10 liter per minute doesn't mean that it will flow at 10 liter per minute. 10 liter per minute means it is ready for 10 liter per minute. Means maximum flow will not go more than 10 liter per minute. This is the meaning of 10 liter per minute. And after that, you will start the procedure. In bariatric surgery also, similarly, we have to use, this is a mini gastric bypass surgery, that is MGB. And we will put the varus needle through the inferior crease of umbilicus. Trocar will be supraumbilical. Later. One epigastric is for Nathanson liver retractor. This is epigastric. One right hypochondrium, one left hypochondrium. Now you will give one a small stab wound over inferior crease of umbilicus. A small stab wound. After that, take the varus needle, long varus needle. This is 20 centimeter varus needle. Long varus needle. And then ask your assistant to lift the abdominal wall. An assistant is lifting, and then you will point it towards the anus. And here this is 1 click and 2 click. And you will enter inside the abdomen. And after that, again take a syringe. And this is irrigation test, freely going. Suction test, nothing is coming. And then hanging drop test. This is hanging drop. And then ask the assistant to lift the abdominal wall. This hanging drop is sucked in. And then you will attach the tubing of insufflator and then start the flow at a rate of, here also, initial varus needle at a rate of 1 liter per minute. And your eyes should be seeing the insufflator. And initially within 5 seconds, your actual pressure should be single digit. If become double digit, that means you are in preperitoneal space. And this way you will wait till the actual pressure reach to pressure. This is the Palmer's point. Palmer's point also you will just give one a small stab wound, and then you take the varus needle and it should be pointed towards the stomach. You should try to perforate the stomach, then you are safe. If you will try to save the stomach, you are in trouble. Nasogastric tube must be there, and stomach must be deflated. And splenomegaly is an absolute contraindication. Absolute contraindication. So you will point it towards the stomach. Don't point towards the anus or towards. If you point towards the anus, you will damage the splenic flexor of colon. So just go perpendicular to abdominal wall, and here you will get 3 click. First click is due to aponeurosis of external oblique. Second click is due to aponeurosis of internal oblique. And third click is due to peritoneum. After that, again you will take syringe, and this is irrigation test, then suction test, and then hanging drop test. And then you will start the insufflation, and you can see here, as soon as insufflation is started, then you can see here, this is insufflating. This patient has incisional hernia. That's why it was used. Here, see, that now distension is started, and here is the hernia. So in this case, if you will go through the umbilicus, what will happen? Bowel will perforate, because if there is some adhesion, that will perforate the bowel. And trocar also has to be introduced same way, pointing towards the stomach. And by a screwing movement, it will enter inside. So this is how you enter in the Palmer's point. Now open technique. Why open technique? Because blind is blind. That's why open technique is demonstrated. Open technique is performed by this Hassan point. This is called Hassan cone. This is Hassan cone. And this is the Hassan trocar. This Hassan trocar is a blunt trocar. It cannot injure you. Completely blunt. And this is called Hassan cone. This Hassan cone can be introduced in any cannula. Suppose this is the cannula. I can put the Hassan cone into this cannula. And there is a screw. I can increase, I can decrease and tight it here. According to thickness of abdominal wall, I can put it like that and I can tight it. After that, this blunt trocar I will introduce. And this become now Hassan put. This is called Hassan put. So Hassan has invented it, and then it is used with the suturing technique. So you will take a, you will give a small incision below the crease of umbilicus, then hold the rectus, cut the rectus, and then you will drop this Hassan port inside like that. And once you will drop it, it has a slit there. And in this slit, you should entangle this suture. I am entangling it like that. Here, you should not tie it, because at the end of surgery, it will help us to close the port. So this is entangle this side, and again we will entangle other side like that. And time to time, it has to be tightened also. And once it is in, then again we will take the trocar out and attach the gas and start. So this is called Hassan trocar. Hassan port is used. So how to do Hassan port? We will have a look and we will see how to perform. So this is Hassan has invented it. That's why it is called Hassan port, and it is very popular all over world by the name of the Hassan technique. That is a open technique. And open technique is very good because open technique has an advantage that you can enter with a very nice, and there will no any chances. You know why? Because closed technique has a definite a small risk. Closed technique is a blind technique, and blind is blind. Blind is blind. So definite a small risk of injury. Because maybe in the childhood patient has some abdominal trauma, and due to that there is adhesion. And in various needle directly you can hit that adhesion. So that's why Hassan technique is considered by many as better than the open technique, by the various needle technique. Here you can see this is a blunt trocar, and this blunt trocar has an advantage that it can easily go and it can enter without any problem. You can enter inside. So this is the Hassan technique, how you will use. So we will see there that this is the Hassan who has invented it in 1974. So you will give a small incision over the inferior crease of umbilicus. 2 Allis forceps will be applied, and then you will give a small incision here, and then apply the Allis forceps either side. And then clear some subcutaneous fat, reach up to the rectus sheath, and in the midline along the linea alba, as we know that we have only one rectus sheath because muscles are either side, and in the midline you have only one rectus sheath because posterior and anterior rectus is fused together. So this will be only one rectus sheath. So you will clear the rectus sheath, and once it is cleared, after that you will take a cocker and you hold the rectus by a cocker, and then lift the abdomen, clear all the fibrous trabecules and fat, and then apply the another cocker from other side, and then lift the abdomen. After that, with the 11 number of knife, you will cut the rectus sheath perpendicular to abdominal wall. If you have cut the, this skin longitudinal, then rectus should cut transverse. And only rectus sheath should cut. You should never ever cut the peritoneum with the knife. Otherwise, Hassan technique will be worse than the varicose technique. Because if the bowel is directly adhered, you will stab it. So only cut the rectus and never go to peritoneum. So this is cutting only rectus sheath. Full thickness rectus sheath is cut. After that, you take a mosquito and bluntly you should puncture the peritoneum. Bluntly you should introduce and open the jaw, and peritoneum is punctured. Then you should use 2 S retractor. This is one S retractor and another S retractor from the other side, and take a bite over the rectus sheath. Full thickness rectus sheath, take a bite. One this side and one other side. Here we can see this is the omentum. Now, according to thickness of abdominal wall, you will adjust the cone. Cone has to be adjusted. And then tight the screw over the cone. And with the blunt trocar, you will introduce it inside the abdomen. So that there will be no injury because trocar is blunt. After that, remove the S retractor. And then fix the suture into a slit here. Either side you will fix it. After that, you will start the flow. Here also, flow should be 1 liter per minute initially. Initially, if you will use high flow rate, patient can get vasovagal shock. There may be vasovagal shock. So it is important that here also flow rate should not be more. And now you will attach the tubing and then you will remove at the end you will remove. Now once you will remove the same suture, once the surgery is over, then same suture will help you to close the port. Port closure is very essential. Proper port closure is very essential in cases of Hassan technique because chances of hernia is high. In our trocar entry with the varus needle technique, even if you don't close the optical port, incidence of hernia is not much. But in open technique, if you will not close the properly, then chances of hernia is much high. So that's why proper closure of the port is essential. And at the end, you should close it nicely. Rectus should be closed separately, skin should be closed separately. And this is how you will do open technique. These techniques we will practice ourselves. As we know that last day of this course, we have the dissection on the live dissection. In that, you yourself will practice the varus needle as well as open technique during the access. Now, VG port. VG port is an optical port which was invented in year 2000. This is VG port. In the VG port, it is always recommended that you should introduce it after creating pneumoperitoneum because FDA has banned it once upon a time. When it was introduced, then few injuries were reported. So FDA has clearly given them the instruction that it should not be used blindly, and it is written here, do not use inside the abdomen without pneumoperitoneum. So you have to create pneumoperitoneum, then only you can use. This has a pistol grip trocar, pistol-like trocar, and normal as usual cannula. So you will give one small stab wound, put the varus needle, create pneumoperitoneum. After that, you introduce the telescope into the trocar, and then you will press over enlarge the incision, press over the abdominal wall, and then you will fire. With each firing, 1 millimeter blade comes out. Here, you will fire it like a pistol, you will fire it by your finger, and with each firing, 1 millimeter sharp blade comes out. Here, this is the blade. You can see this is a very sharp blade. This is the blade comes out with each firing. It cuts layers of the abdominal wall, layer by layer, subcutaneous fat, then fascia, then preperitoneal, then rectus, and then preperitoneal fat, and then peritoneum. So this is the actual clinical footage. We can see this is facial layer. After that, it is cutting the rectus, then cutting the preperitoneal fat, then cutting the peritoneum, and we are in. So this is called VG port. After that, we have Turnemian trocar. This Turnemian trocar is a German surgeon This was a German whose name was Terminian. So this is Starch is marketing it. It has a blade like at the tip, and by a screwing movement, it enters inside. So this is called Ternemian trocar. After that, we have a strep trocar. A strep trocar is also called radially dilating trocar. It is a radially dilating. So initially you will put a 3 mm, and over that you will push this 10 mm. So it will stretch the, only a skin has to be cut 10 mm, and other layers you don't have to cut. First you push this 3 mm, and over this 3 mm you will pierce this 10 mm, and after that it will radially dilating it. So this has advantage that you have a less hernia, and there is less, no port closure is required. No port closure, because it is not cutting the layers, it is just dilating the layers. Only a skin closure is required. This is called a strep trocar. But problem is it is strictly disposable. You can never use it second time. So this was regarding the access technique. In this we have only learned the primary port. Second part of this lecture is secondary port, that comes in baseball diamond concept of port position. This part is another lecture in which we need at least 1.5 hour time. So this I will take after lunch, I will take later. So this was the access technique in which we have only discussed the primary port, how to put. Second part is very important because that will give you the concept of how to put secondary port. Because secondary port is more important in laparoscopy, because if your secondary port is at wrong place, throughout the surgery you will struggle. Primary port is only important for safety point of view. Because if primary port is wrongly introduced, your patient may have the injury of the aorta, injury of the bowel, injury of the bladder, injury of the iliac vessel. But secondary port is more important for the ergonomics point of view. And every patient need different port. For that we have to learn a physics that is called baseball diamond concept of the port position, so that you can put the port in your every case.